Together, we navigate
new frontiers.
We are the NMP.
We heal with zeal.
Together, we navigate
New frontiers.
We are the NMP.
We heal with zeal.
Together, we navigate
New frontiers.
We are the NMP.
We heal with zeal.
Together, we navigate
New frontiers.
Good afternoon, friends. Myself, Dr. Vikram Patra, on behalf of MGM Medical College, Department of Pediatrics, and IIP Navi Mumbai. We welcome you all for Sunday Academic Bonanza session. For introduction of the topic, may I request our President Dr. Jitendra Devani to carry on this session. Welcome, you, sir.
Good afternoon, all. On behalf of MGM IHS and Department of Pediatrics, MGM IHS and IIP Navi Mumbai, I welcome you all. Friends, we are celebrating Child and Adolescent Health Care Week from 8th of November to 15th of November. And as a part of celebration of this activity, we have kept today's Sunday box office session with the eminent speakers. Friends, we know that malnutrition not necessarily include the one end of the spectrum, that is the PEM and kwashiorkor and marasmus, but the other end of the spectrum is the children who are having excess of weight and going beyond the BMI range to call it as a obesity. So over a period of time, if you see the trend, the obesity is increasing or rising in the childhood, not just in this lockdown period, but since ages. So last 8 months of inactivity by children because they are not going to school, they are not having playground to play, they are homebound and not doing any physical exertion. So when they came for immunization, once lockdown opened, we found that they have increased, they have put on their weight to a great extent, and this is a very alarming trend. So to discuss in more depth about the health of the child and increasing trend of obesity, we need to go in depth of that. So as a pediatrician, we need to pick this up at early point and introduce the early interventions at correct time so that we can reverse the trend, and healthy reversal of the trend is required rather than restricting the food items and making them exercise without knowing what is correct and what is not. So we are going to have this wonderful session. For today's session, we have Dr. Vijay Kamble, our head of the Department of Pediatrics. Sir is a very enthusiastic person in the department, and his calm demeanor always fascinates all of us. Thank you, sir, for joining this session. To moderate this session, we have one more fitness freak who always believes that person should be in a correct shape and size so that aging should not catch him up early. At the same time, the child diseases also should not catch the person. So we have Dr. Prashant VK to moderate this session. Welcome, Dr. Prashant VK. I request Dr. Prashant VK to take over the proceedings.
Thank you, Dr. Jitendra. Today's topic is very interesting. Before that, good afternoon and welcome you all on behalf of IIT Navi Mumbai and myself, Dr. Prashant VK. As Dr. Jitendra rightly said, today we are celebrating IIT Healthy Lifestyle Day as a part of IIT Child and Adolescent Healthcare Week. To more about the topic, friends, as per WHO, globally 1.9 million people were affected, more than 20 years of age globally. Even in India, as per ICMR 2015, 135 million people were affected, and the incidence in adult is 65%. Therefore, 2/3 of all the children are at the risk of developing the disease in their lifetime. Even the incidence overall, if you consider, is increasing up to the tune of 300% in last 4 decades. So you can guess the uh, gist of the today's topic. It become an important pediatric public health problem associated with the risk of childhood, complication in childhood, and mortality and morbidity throughout the adult life. I think Dr. Jitendra rightly said, in last 6 months of lockdown also contributed immensely to increase the prevalence. Yes, you people are thinking correct. I'm talking about today's Sunday academic bonanza topic, that is the obesity, correctly said, the neglected pandemic. And to solve all the queries related to today's topic, we have with us Professor and Head of the Department, Dr. Vijay Kamale sir, NGM Medical College and Hospital. Sir is a great academician, and already Dr. Jitendra said is a great human being also. So welcome sir. Before I can commence the session, I just request all the participants, please drop all your queries in chat box. Sir, please start the session. Please unmute yourself.
Hello, hello everybody.
Yes, sir.
Visible? PPT
Yes.
also visible, na?
No, not yet.
Ah,
Please share the PPTs.
अच्छा, okay. Hello, hello everybody. Visible? PPT also visible.
Sir, your voice is echoing. Some other instrument is on. Is switched.
Okay, okay.
Mobile or something.
Hello.
Sir, your voice is echoing.
Hello. Shardul.
Sir, please take other electronic equipment out of the room.
तू घेऊन जा. एको येतोय. याचा. घेऊन जा. Hello. आता?
Yes, sir. Yes.
Okay. So
Slide off. Make
I
it
can
full
start,
screen.
start now.
You
Can
can
I
make
start?
full screen.
Hello.
You can make full screen, sir.
अच्छा, okay. Okay. So,
Yes.
thank you, Team IAP. Thank you, Moderator Dr. Prashant VK, for introducing me nicely. And today we have decided, as a part of week, IAP week, to start the sessions, to start the program of week, my lecture regarding childhood obesity, a neglected pandemic. Everybody is talking about pandemic since last 7 months. So basically, why this may be pandemic, whether it is epidemic, endemic, it will become, or it will become pandemic, that time will decide, and that I will share with you how it can become pandemic. So basically, childhood obesity is a critical medical and public health problem. It is not only medical, it is a public health problem nowadays. Prevalence is increasing, incidence increases gradually as age advances, and you can see as in older age people are now affected more, but gradually younger, even smaller children are also getting involved. Then there is increased risk of complications as the obesity go on increasing, and now it is linked to more deaths than underweight. Previously underweight was found to worldwide over, except some part of the world like sub-Saharan Africa and Southeast Asia. But prediction is that WHO has predicted that current generation of children will be having shorter life expectancy than that of their parents. So we have to be worried, because we may live longer, but our next generation probably have little shorter lifespan. So that has to be taken into consideration, and the preventive method have to be taken. As Dr. Jitendra said, obesity is one side of double burden of malnutrition. On one side there is a undernutrition, other side there is a overnutrition. And today, worldwide, as I said, mortality also is increasing and prevalence also is increasing. everywhere. And the vast majority of overweight or obese children live in developing countries because these sub-Saharan Africa and Asia are the most populous countries of the world. And it is found that the rate of increase has been more than 30% higher than that of the developed countries as a population wise, the number wise. So WHO says that the issue has grown into epidemic proportion now. Probably pandemic it will happen, nobody can predict at what time, because 4 million people are dying each year as a result of being overweight. That is 2017 data. And in many persons there is an increased risk of premature onset of diseases. And studies have found out that without intervention, children and adolescents with obesity will likely to continue obese into adulthood. So that is how we have to act little early. With 14.4 million obese children, India's second highest number of obese children in the world next to China. And the prevalence of overweight and obesity in children is 15%. And there are various studies. In some studies, it has shot up to 35 to 40% also. This is worrying trend. So, as I said, epidemic will become endemic, but has it become pandemic yet? So, the various studies have shown that it can become pandemic very soon if the measures are not taken properly. So these are the various obesity studies all over India which have happened in last 10 to 12 years, and you can see every state, every small city, wherever studies have been done, they have found out the incidence and prevalence is increasing. WHO, China and Vijay and Kamala are probably very famous for spreading rumors. WHO has already said in September, world may be prepared for next pandemic. Which pandemic? I can say it can be obesity pandemic. That is as a joke. So friends, now back to the basics, that is pathology. The definition of obesity is abnormal growth of adipose tissue due to enlargement of fat cell size, that is hypertrophy, or increase in fat cell number, that is hyperplastic, or it can be combination of both. So pathology wise, there can be increase in size as well as number. Overweight, it is usually due to obesity only, but can arise from abnormal muscle mass development or fluid retention. So overweight children have to be assessed really properly what is the cause of, and with proper assessment. Obese usually because of adipose tissue only. So how do you define childhood obesity? Through the measure called as body mass index. Overweight is defined as BMI at or above 85th percentile or below 95th percentile for children and teens of same age and sex. This is important, that I will explain later on. Whereas obesity is obviously more than 95th percentile for children and teens of same sex and age. BMI, as everybody knows, is calculated as child's weight in kilograms divided by square of height in meters. And that is age specific as it is done. A child's weight status is determined by using age and sex specific percentile for BMI rather than BMI categories for adults where it is fixed. BMI is fixed. But here we are using weight and height properly and age specific. This is because children's body composition varies as they age. They increase in age, varies between boys and girls also because of various issues like endocrine issues. So how it increases? There is high adiposity in infancy. Infants are relatively obese. But this obesity will decrease till 5.5 years. And 5.5 years onwards, it will go on increasing till early adulthood and probably remain same, and then depends how it is increasing properly or no. So this around 5 to 5 year is called a rebound. So at this rebound of weight increase can happen. So that we have to be careful, but it is not that we have to be careful at 5 and 5.5 years. At every age, we have to be careful. So for the categorization of obesity, above 2 years, BMI percentiles have been taken into consideration, and for below 2 years, weight for length percentile, which are the standard. So above 2 years, if anybody comes, you see BMI percentiles. Below 2 years, if you assess, if you suspect obese, go for weight and length percentiles, which are given, which are the standard. Anything. So WHO has basically given this adult classification, which is not helpful for a childhood obesity. Like Dr. Jitendra said, you are seeing the children pre-COVID era and post-COVID era. So this is the child who is around 3-year-old. 27 February he was 13.6, and now he came for assessment, routine assessment or some symptom assessment. In 31st August, he had become 21.13, a massive increase of almost 8 kg. So I was not that suspectful. So I calculated BMI, it is 24.9. 24.9 as far as the adult is concerned, it can be borderline. But as I said, for here children, we should not see the adult classification. We have to see for the BMI percentiles. So how this will happen? So see this BMI percentiles. As I said, initially children are little obese till 2 years of age. After 2 years, they go on decreasing. Over here at around 5 to 5, there is an increase in the body BMI till adulthood. So if a child, a 10-year-old boy with BMI of 23, if you consider, so 10-year with BMI of 23 would be in the obese category. So 10-year-old boy, but 15-year-old boy with BMI of 23, same BMI, he can be normal. So this is the importance of this weight chart. So age specific and sex specific charts have to be considered for about 2 years. This is the important message by this slide I want to share with you. So always consider age specific and sex specific BMI charts in children about 2 years of age, not plain simple BMI classification given by WHO. But BMI may be imperfect. Nothing is perfect. So it is whether, although it is accurate and direct measurement of adiposity, BMI can be imperfect sometimes because it will not take into consideration muscle mass. And in heavier children, association of BMI to body fat percent, however, it has been seen that in older children, BMI to body fat percentage is much stronger. But in athletic children, it can vary because they are muscular, their muscle weight, bone weight is more, so it can vary. So because BMI percentile are important, there are various, depending upon the countries and standards, there are various cutoffs. We may not go into that. We are following WHO cutoffs and WHO charts. So obesity in children classified not as a WHO typical classification. So it is overweight, which is greater than or equal to 85 and less than 95th percentile. Class 1 is greater than or equal to 95th percentile, but less than 120% of the 95th percentile. Class 2 is greater than or equal to 120 percentile percentage of 95th percentile, but less than 140% of 95th percentile. Or it can be as a WHO BMI greater than or equal to 35, whichever is lower. Class 3, which is severe obesity, is greater than or equal to 140% of the 95th percentile, or BMI greater than or equal to 40, as suggested by WHO. After this understanding, we will go for the pathophysiology of weight regulation, how weight is regulated in a child or even an adult person. So weight is regulated basically by simple formula, that is energy intake versus energy expenditure. If you take lot of energy, weight will go and increase. So you have to expend it. If you do lot of expenditure, weight probably will decrease, but this is not that simple. Physical activity may cause obesity. Inactivity may cause obesity, which in turn restricts activity, and this is the vicious circles. But sometimes it is seen that larger session of physical activity may not be effective. So it should be a smaller increments in exercise throughout day is more effective. Sleep and other factors also will have an effect on weight regulation. That will come later on. But most important is environment. So if you see older environments, we can see our fathers, ancestors, they had unreliable food supply. They were highly physically active to procure food to survive. and there is a weak physiological regulation of energy was effective at that. But today's environment is not like that. There is a constant supply of high energy food with reduced needs of physical activity that you must have observed, especially in COVID. Now we are become little active. There are certain misconceptions, that is whether this gynoid, android, obesity, but they are now obsolete terms. Previously, high fat diet was only considered as a culprit, but it is not that. Even sugars, refined sugars, total fat, and what type of fat it is, that is also important. That will come. So coming back to obesity of Indians. Indians are genetically predisposed. Probably we are having a lot of IUGR in our country for obesity. And however, the rapid increase in childhood obesity is largely due to environmental influence, although it is seen where various hypotheses are there. But mainly it is environmental influence. So environment plays a lot of important role. Economic prosperity leads to change in diet from traditional to modern foods, which are rich in fat and sugar. Urbanization is leading to increase in sedentary lifestyles. Everybody is having car, scooter, and for moving. So that physical activity has been decreased. In short, obesity is a result of various complex interactions of variables like genetic. I will not go into too much details of this. Behavioral problems, how we behave here, what is environmental influence, and one more important criteria which is coming now, microbiome is probably having effect on obesity. As I said, there are multiple factors, variables, and importance of each of these mechanisms is subject of ongoing research. A lot of research has been going on, and in individual population, various population, it can vary from various factor to factor. So this is just to demonstrate how we are going towards the endemicity from our ancestors. What was there, that is Homo sapiens to Homo erectus, etc. We are going towards obesity gradually, but this in last 2000 years there is a fast change because we are going towards more of caloric beverages, absence of less activity. Probably historical evolution will tell how it will go. But for practical purpose, how the diet, how the food intake, how the food exhaustion is basically based on brain or neuroendocrine axis. Brain has very good capacity to match intake and expenditure with less than 1.255 error only. There are two important centers, that is nucleus accumbens, which controls hedonic response to food, and hypothalamus, which controls food intake. And monitoring of stored fuels, short-term control of food intake, that is appetite and satiety, occurs through feedback loops linking adipose tissue, GIT, and CNS. So three main factors are there for taking food or expending food or not taking food is adipose tissue in the body, GIT, and CNS. As I said, hypothalamus is one of the anorexia. These are also called as pro-opiomelanocortin neurons, orexogenic neurons, which increase the appetite. They are acting through the neuropeptide Y. And these two neurons, neurotransmitters, they have control, they have influence over leptin, lipids, amylin, peptide YY, and glucagon-like peptides, ghrelin, and gastric inhibitors. So these two neurotransmitters will be having influence on these hormones and their complex interaction. Probably I will not go into details of that thing. For example, but I will give after meals glucose level increase with insulin levels into the blood. Insulin activates POMC neurons and suppresses NPY neurons, which promotes satiety. So if you take a lot of sugars, it will promote satiety and there is a cessation of eating. This is the simplest form of loop. And there are multiple loops which can control, and if any loop there is a problem, obesity can intervene, or even a undernutrition can. But what happens in obese state, anorexigenic pathway is not activated appropriately by signaling molecules. So they go on taking foods. And similar problems can be found in other pathways also. So this is stomach. So in preprandial, before food, if somebody is fasting, stomach will have produce ghrelin through this mechanism. Ghrelin will increase food intake stimulation. And food intake stimulation will stimulate hypothalamus or brainstem, and various peptide neuropeptides will coming into the picture. Similar thing happens during and after postprandial period. The food intake inhibition will be there. What is important? Substances related to obesity and food intake. These are adiponectin and leptin. These adipocytes secrete adiponectin into blood with reduced levels in response to obesity, increased levels in response to fasting. So lower adiponectin levels are associated with lower insulin sensitivity and adverse CV outcomes, cardiovascular outcomes. So it is important. Usually we think increase ho gaya, inflammatory markers at the end is the problem, but for adiponectin it is not like that. Lower adiponectin is dangerous in the obesity. The rest of the other inflammatory markers are markedly increased. So other inflammatory markers can be markedly increased like interleukin 6, tumor necrosis factor, or CRP. Basically, interleukin 6 stimulates production of C-reactive proteins in the liver, and CRP is marker of inflammation and might link obesity, coronary disease, and subclinical infection. And that is what these are the markers in COVID also. What we are seeing in our first child who died of COVID was a morbid obese and had pre-diabetic mellitus. This is the first death in MGMV evidence because of obesity, and here in COVID also you get IL-6, CRP, etc. increase. So there is lot of relation of this COVID and obesity, and it has been proved also. Another hormone is leptin, which is little theoretical molecule, but leptin is directly involved in satiety, and low leptin stimulates food intake, and high levels inhibit hunger. However, leptin is probably in the evolution since long it has been there. So it is important for diagnosis in a genetic cases basically, but not as a diagnostic measure for obesity. But adiponectin as a inflammatory marker is very, very important. Coming back to environment, I have already talked, but what are the factors that promote overeating is availability of fast food as snacks. Easy accessibility, low cost, good taste, big portion size, high fat content, and energy-dense soft drinks. These are the various environmental factors which are promoting obesity in today's children and adolescents. Regarding environment, one important factor I will have to mention is lack of public information. Some people cannot judge which products are high in fat and by how much. Although most of the products, ready-made or other thing, they are depicting on the packets how much fat, how much proteins, how much carbohydrates, etc. is there. But we don't read that and go on eating. Food manufacturers, according to study, 92% of the elementary school do not provide daily physical education classes for all students throughout entire. So that is because that is not given that much importance. So lack of public, and nobody asks aaj khela ki nahi. That is, no parents is going to ask to the child. He will ask only kitna khana khaya. So after these factors, we will go for how to identify and assess these kids and adolescents. Basically, obesity is often identified as a part of routine medical care and school examination. Child and family may be unaware of problem many times. Patient comes to you, we take BMI, we go to the charts and see where is the child lying into that chart, and then declare the child is obese or overweight. This make the parents become unhappy with doctors. They want to change doctors also sometimes because of this. Your doctor is not good, and they will start raising the issues. They will say my maternal side is obese, they are like that. My paternal side is obese, so it can be because of that. And they just may respond with denial initially, and they don't have that much of apparent lack of concern also for the obesity. They'll feel chalo dekhenge, baad mein dekhenge. That attitude is there. Sometimes, so this commonest presentation of the children is during routine school examination or during routine doctor's examination. Rarely nowadays children families will bring child if there is a comorbidity in the child due to obesity. So whatever the situation child has come to you, it is necessary to begin by helping family, because always it is a chronic disorder like nephrotic syndrome. Unless you explain the thing, they will not hear and they will do doctor to doctor shopping. So it is necessary to begin by helping the family first. How you will be helping is motivational interviewing. So assess their engagement, how they are engaged for the problem of obesity. Whether this is intrinsic or extrinsic, because somebody is saying that the motivation should be intrinsic. And exploration of their ambivalence towards behavior change, whether they will be changing their behavior or because of pressure, family pressure, they will be continuing with that thing only. So how to counsel and when to investigate is also part of care and the key for the management of obesity. They will ask many questions then, what is visceral fat, hepatic, because usually visceral fat and hepatic fat are not reflected through BMI traditionally. So we have to take little measurement just to involve them, that is skin fold thickness, neck circumference. Many studies are there on this thing. Nowadays, very few people are doing these studies because there are a lot of methodological issues with these measurements like skin fold thickness, neck circumference, waist and hip circumference. Lot of variations are there. So, but still it is popular because somebody is saying that thing. So I will talk 1 minute on skin fold thickness. That is, Harpenden skin calipers are used. Sites are usually mid triceps, biceps, subscapular and suprailiac fat area. And sum of measurement should be less than 40 millimeters in boys and 50 millimeters in girls to declare a probable obesity. It is not diagnostic. But as I said, unfortunately, it is not standardized even in adults. So forget about the children. Additional methods which are of the research methods can be bioelectric impedance, air displacement plethysmography that we have learned in our physiology, total body potassium content, DEXA, CT and MRI, because on MRI fat is seen very well. So basically why this assessment is important, to just engage the parents, because you cannot declare only based on BMI you are obese. So you have to do little bit assessment. Assessment in detail also is required after counseling or motivational interviewing is for 3 purposes. That is to exclude underlying pathology. What is the pathology or any genetic factor is there or no, if it is very morbid. To evaluate potential comorbidities. What other predisposition of comorbidity is there in this child or adolescent. And assessment to identify underlying behavioral or environmental variables that can be targeted. That is important from management point of view. So not only medical examination, behavioral and environmental variables also have to be studied. So it is a multidisciplinary approach for if you find any overweight or obese child. So what are underlying pathology? Iatrogenic, some drugs can cause, or some medication, some surgery can cause. Endocrine, like hypothyroidism or any other things. I'm not going away into details of this. Developmental disabilities. A developmental disabled child who is just eating, not moving, will have obesity. Genetic is also previously any obese child, some 20 years back, genetic hormonal studies, but now environmental and behavioral studies are very, very important. So common genetic are Prader-Willi and melanocortin 4 receptor mutation. Both are having strong familial history. Prader-Willi is the example of genetic imprinting. So then only you have to refer. So this is the very complex flow chart. Not very complex, but if you go through this flow chart, probably you will make the diagnosis. So if you find BMI more than 85%, and history and physical examination is required. If history and physical examination is abnormal, additional evaluation based on clinical findings. If there is a decreased growth velocity, probably endocrine evaluation. Neurodevelopmental abnormalities or severe hyperphagia, then genetic evaluation. If there is a history of CNS injury, both asphyxia or lateral CNS injury, hypothalamic obesity. Then in between, a lot of antipsychotic drug use is there. Evaluate psychological wise, re-evaluate drug therapy. If history and physical examination is normal, that is the commonest population we will come across, then evaluate obesity comorbidities. So lot of comorbidities are there. Then initiate life cycle changes and specific treatment for comorbidity. And if comorbidity is absent, still lifestyle changes. So lifestyle changes is the commonest for all sort of obesity. And if in spite of this, treatment of comorbidities, changing of lifestyles properly, there is no improvement, pharmacotherapy. And if there is a weight loss or weight stabilization, then maintain support of lifestyle changes and comorbidity. There is continued weight gain, evaluate obesity once again. Then if there is a developmental delay, obviously genetic studies have to be done, and these are the various diseases like Prader-Willi, congenital leptin deficiency, moderate molecular genetic studies for leptin, POMC deficiency, etc. This is a complex thing that will go. So comorbidities as a part of evaluation is very, very important. So history of timing, when the comorbid started and what are the trigger factors have to be found out, and any family history or genetic disorder has also to be found out. These are the important comorbidities, that is hypertension. So in hypertension, we have to do serial testing of blood pressure, type 2 diabetes mellitus, polycystic ovarian disease, gallbladder disease, non-alcoholic fatty liver disease, and dyslipidemia. So what are the symptoms and laboratory findings are given in this table. So everybody knows in hypertension what you have to do: serial blood pressure monitoring, you can do electrolytes, urine analysis, electrolytes, blood urea, nitrogen, creatinine, etc. for rest of the things. And you have to refer to particular specialty also if you find out on possible symptoms of any comorbidities. Other comorbidities are Brown's disease, the orthopedic problem, tibial bending, slip caput femur represents, that is hip problem, pseudotumor cerebri, headache, vomiting, etc. will be there. Behavioral complications are very, very important in this obesity problem. These are anxiety, depression, low self-esteem, disorder eating, signs of depression, worsening of school performance, social isolation, problem of bullying or being bullied. Because of this obesity or behavioral problems, they will having either one of the terminology, that is anorexia nervosa or bulimia, and that will lead to abnormal obesity or even undernutrition. So for that thing, lot of evaluation has to, psychological evaluation, various stress symptom checklist has to be done. Another problem, respiratory or serious problem, is obstructive sleep apnea. So after this comorbidity assessment, we have to assess child's typical dietary intake, physical activity, screen media use, other sedentary behaviors, and sleep habits. So for complete assessment, multidisciplinary approach and a obesity center is required, because child cannot go here and there for a various stage. So some center is the now need of our in India to set up centers regarding obesity management. As far as dietary history is concerned, 24-hour typically dietary recall is required initially. In that, number of meals and snacks per day, food and beverages with added sugar, how much is taking, and different food groups and portion size is very, very important. Physical activity, I don't have to talk to Navi Mumbai IAP because they are all physically active, and that has been shown into West Zone Pediatric Conference. They have won lot of laurels in physical activity fitness tests. So, and everybody, I think most of the 5% of the Navi Mumbai IAP pediatricians are very, very fit and not obese. That I will come later on. Screen media. Nowadays, it's very difficult to differentiate screen media, whether it is time spent during academics, because everything is going on now on mobile or entertainment. So if somebody is having entertainment screen media more than 2 hours, that is dangerous. Next, as I said, is lifestyle behavior. So obesity related behavior, challenging tasks, and lot of biases, especially because this behavior is not standardized. Each and every person will come with his own checklist. A person or child will not report properly. Parent also may not report properly. They are busy. So it is done because it is done through various skin form, which are most of them are online. But what is important is patient-centered communication techniques and behavioral counseling in spite of this. So lifestyle history, behavior history has also to be assessed very well and frequently. Then physical examination obviously is more important. And as I already was during comorbidity, what has to be done into. After that, which are the important screening tests we have to do is fasting blood sugar or HbA1c, LFT lipid profile, TSH, and PCOD work in adolescent female child. So these are the standard values of laboratory test, normal values. If beyond this, again, probable comorbidity, we have to treat that comorbidity. Which are the medication, just to complete the list? So steroids, antipsychotic like olanzapine, clozapine, risperidone, lithium, anti-epileptic like valproate, carbamazepine, gabapentin, cyproheptadine, which is used left and right by general practitioners for as a apparent, it can cause also obesity, and propranolol or other beta blockers. So that history has to be taken. After this big history and assessment, we'll go for the prevention. Prevention is basically a primary care effort. We as the plain simple pedestrian, it is our effort for prevention at each and every visit. So promoting healthy lifestyle at home by at home, school and community level. Out of these first 1000 days, that is the period from conception to 2 years, are very, very important. So even gynecologists are important for prevention of obesity as given by government. These 1000 days are very, very important, and it is increasingly considered as recognized as a modifiable period. So at this stage only primary prevention will start. So most of the causes of overweight and obesity are preventable and reversible, but timely action has to be taken. But still, in spite of this, so much of propaganda over the period, government as well private, no country has yet to reverse the growth of this epidemic. So there are certain other factors, probably economic factors related to this. WHO has given standard guidelines regarding prevention, that is increase physical activity of at least 60 minutes daily, reduce or stop consumption of sugar sweetened beverages, eat 5 servings of fruits and vegetables daily. This is for general adult as well as child. Have 2 hours or less of screen time daily, decrease total sugar intake of less than 25 grams per day, achieve normal sleep time and patterns. So these are the WHO's standard guidelines for each and every child and adult. So as I said, aggressive intervention in early childhood starting from conception is required, and if it is to prevent epidemic going into endemicity and pandemicity, more effective intervention at early age is required, because in growing children, relatively small weight loss, they are growing, so relatively small weight loss or even weight maintenance can bring an obese child to a healthy weight range. This is important. You should not increase abnormally weight gain. So even small weight loss is adequate, not like adult where they have to lose the weight. Here even small weight loss or even the weight maintained, if it is weight maintained, you can encourage parents. So typical strategy of after diagnosing obesity can go up to minimum 26 to 75 hours of counseling spread over 6 months. This is given by US task force. So for an obese child to manage, this much counseling, this much treatment hours are required for each and every obese child to maintain or to lose some weight. And this requires definitely referral to a special center, which is difficult in India at this time. Probably MGM can take the initiative for that thing. Family-based interventions are more important than the treating child alone. That has to be, I have already stressed in initial part. So basically nutrition counseling, physical activity counseling and behavior change, because this may be repetition, but this is important. So goals of program are, what are the policy components? Choosing a strategy to change environment, changing the behavior, and to best begin with the small changes. You cannot give drastic changes for it. You have to decrease this much amount of weight, you have to do all these things, you have to stop sugar at all, etc. So to best begin with small changes, as in any chronic diseases. Some objectives will be measured in primary prevention of weight gain, prevention of further weight gain, weight loss will be happy, and prevention of weight regain. That is also important. So whatever they have lost, it should not be regained. So continuation of the lifestyle changes and other management will be important. So basically, obesity management is a social cognitive therapy, not medical therapy much. Social cognitive therapy is much. And in social cognitive therapy, what is important is goal setting. Small goal setting is required, and then implementation plans. That is why the task force, US task force, is given 26 to 75 hours of planning in 6 months. Behavior monitoring, that is, and changing environment. So at each and every visit, the child with parents is coming. We have to assess all this, and each and every visit, we have to give 2 goals and frequent follow-up. And this is the key. And we have seen that many obesity center, private mostly are there. They are doing this, and but lot of money is involved in that. So patient will go. So whether it is intrinsic or extrinsic motivation, that time will take, and they start gaining weight again because they are driven by money. So what are the education points to address for the diet is resist temptation to always, you have to finish all the plate, whatever is given you have to finish. That is the stress by mothers or parents, sab kuch khatam kar do. But for obesity it is not that. Whatever he is taking, starts, he is saying no, that is enough, you stop, don't give everything. Do not eat while talking on phone or watching TV. Avoid appetizer and dessert in restaurants. Eat healthy snack before going to a holiday party. So if you are going for it, eat at home initially and then go, so that you will feel full. You will not eat much, because in parties there is lot of refined sugars and fatty material. Eating habit has to be stressed. So there can be small frequent meals at regular scheduled times. Regularly scheduled snacks of fruits and vegetables. Important is do not skip meals, because what happens, they are told to lessen the diet, so they will skip meals, but that is not required. That will again initiate the vicious cycle of obesity and various hormones interplay, and this complex interplay will again deviate the neuroendocrine axis. No foods are off limits. However, in order to encourage success, moderation is the key. So you should not say yes, bandi karo, waisa nahi hai. You have to take all sort of foods, but in a moderate or small amount. What is important again is, as I said, the portion size, how much the child is eating. Most of us underestimate the amount of food we eat. Limiting portion size is critical for good health. Check serving sizes listed on the packages. So if you are bringing some ready-made foods or some other snacks, see how much, what is the portion size, and then decide accordingly size. So this is typical traffic light, green, yellow, red light foods. What has to be eaten, how much quantity, types, and quality. So green light foods are low calorie, high fiber, low fat, and nutrient dense. These can be fruits and vegetables. They can be consumed in unlimited quantity. As I said, minimum 5 servings can be taken per day of these fruits and vegetables. Yellow light foods are nutrient dense but higher in calories and fat. These are lean meats, dairy, starch, and grains. They can be taken into limited quantity. Red light foods are high in calories and sugar and fat. They are fatty meals, sugar sweetened beverages, and fried foods. They should be preferably avoided, or it can be taken during party only or infrequent. Again, coming back to diet, which is very important part, so I will share some my thoughts. So add vegetables to as many as thing possible. Eat several servings of fruit daily. Avoid processed or fried foods, red meat, ghee, butter, cream, and chocolates. Some fat is needed to provide essential nutrients to the body. For example, vegetable oils, they can be required. But avoid saturated fats like dalda, etc. Diwali. Watch foods labeled fat-free or low-fat, because they are not low-fat. Ultimately, we may consume more calories overall. Traditionally, dieters, those who are on diet, cut cereals, pasta, and potatoes to control weight. But that is not true. These are the sources of complex carbohydrates that help you feel full and maintain the healthy weight. Avoid high fat toppings on carbohydrates and try plain or low fat yogurt. Usually what happens, food high in proteins are often high in fats, so limit proteins to 10 to 15% of total daily caloric intake. What about fasting? Fasting for weight loss. That is, fasting is popular since ages in our tradition. So fasting is popular because it can provide dramatic weight loss, but it is primarily water rather than fat. So water is lost to fasting, not the fat. Lost water is regained quickly when eating is resumed. And prolonged fasting is not recommended and may lead to nutritional imbalances. So fasting is not the answer. What is important in the long run is daily maintenance of food diaries. Most people do not realize that amount of food they eat per day and what they are doing at the exact time they are eating that food. So food diary is important that is behavior change. Suggest taking notebooks and taking a 1 week diary. Note in diary all intake of food, snacks, drinks, activities while eating, etc. Next important our favorite that is physical activity. Physical activity burns calories, keeps metabolism geared towards using food for energy instead of storing it for fat. There are two types of physical activity. One is house activity or daily activities and other is sports or structured exercise. For each and every physical activity begins slow and gradually increase exercise time to 30 to 60 minutes. You cannot start on day one only 30 minutes or 60 minutes of exercise of structured exercise. This is our icon, idol and inspiration. A pediatrician as role models. And as I said, most of the pediatricians of Navi Mumbai are as fit because of this couple probably. So everybody knows that thing. So exercise in the bottom line, use life activity for not formal exercise programs whenever possible. Find partners, friends or family. Home activities will consume 3 calories per minute. Walking will consume 4 calories per minute. Jogging will 6 calories per minute. Running 8 calories per minute. Running up to stairs 10 calories per minute. So decide how much calorie you want to consume, but before that you have to have energy intake. Without energy intake you cannot lose calories. So exercise and lifestyle physical both are important for the maintenance of weight. Behavior changes, as I said, is the third component. Most people resist changes. Patterns are learned over lifetime. So changes can be TV, internet, games. Family therapy is very, very important. And obesity management is a lot of psychological dimension, as I said. Again, to repeat, for overweight children, small reduction in calories allows gradual decline in BMI. For obese children and adolescent, weight loss of 0.5 to 1 kg per week is the goal. Rapid weight loss can lead to electrolyte disturbances like hypokalemia, increased uric acid, etc. Special diets like high protein diets are not recommended. Somebody was previously called as Atkins diet. They are not recommended now. What, as I said again, motivational follow-up is in. So motivational interviewing and motivational follow-up at each every visit is very, very important. Address any problems that arise and help them towards additional behavior changes. Be empathetic and non-judgmental during discussions and always consider cultural differences and dietary differences. There are new ideas like themed office visit, like what we are having various themes during our various cultural programs. So theme, what this theme of this diet, so theme office visits in that is in developed countries. And obesity groups like Alcoholic Anonymous, Obesity Anonymous groups can also be formed out. After this routine management, there is a time to referral, because pediatrics or everywhere referral is very, very important when indicated. Unnecessary referrals are not important, but referring is important. There are various online or WhatsApp things like these centers or advertised centers, but they are not studied well probably. And referring also in development is very difficult because they are having a vast area. In our country, referring properly has become, unless good studies, good. So good thing I showed in the map in India, many centers are doing a lot of studies. Probably in future we'll have good referral centers. So it is better to refer to center which is scientific and evidence based, and it has expertise and good follow-up facilities. Just referring by some advertise is not good. It should have good follow-up facility and expertise in all fields, including dietitian, physiotherapist or physical education specialist, not only qualified but those who are having good experience, and the psychologist. These are the important part, and other subspecialties also important. So subspecialties are required when child is having comorbidity. And while referring for subspecialty, also check again motivation of the family and child. That also has to be assessed. Then only he will go to subspecialty. So basically, as I said, it is a psychological treatment, and studies have shown that there are two types of treatment. One can be IPD or CAMS treatment, which is combined treatment, or it can be OPD treatment. So IPD treatment, that is called as immersion treatment, has resulted in much more improvement in percentage of body weight increases. This is a meta-analytic study. So for little overweight, it is better to give IPD treatment of 2 to 6 months, depending upon for those, so that it will be maintained. OPD treatment decreases weight, but up to the 8.2% only. But many children, it can be adequate. For severe obesity, definitely short-term inpatient treatment is required. After this lifestyle behavioral changes comes pharmacotherapy. It is usually important for severe obesity, but unfortunately currently no safe or effective agent is available. There are two studied molecules. These are orlistat, gastroenteral lipase inhibitor, and sibutramine, serotonin and norepinephrine reuptake inhibitor. But whenever pharmacotherapy is started, it should be started with lifestyle changes and dietary interventions. So studies in sibutramine showed decreased BMI instead than the orlistat, but sibutramine has been voluntarily withdrawn because of many side effects. Orlistat only is approved by US FDA till now. Another two important, very favorite medicines are metformin, which is insulin sensitizer, and lorcaserin, which is glucagon-like peptide. That has shown modest efficacy in small trials, but it is used in adults in large quantity nowadays. What is important now in adults is the combination of treatment. So lorcaserin, and other combination treatment like phentermine, topiramate, bupropion, and naltrexone, or liraglutide injection. These are the tried in adults and adolescents, not small children. They have shown variable effect and safety. So in short, pharmacotherapy only in patients with severe obesity where weight loss can ease symptoms severity. So if they have a lot of symptoms, you can start pharmacotherapy. But in pediatrics, randomized control trials are urgently needed to determine their efficacy. After that comes surgery, that is bariatric surgery. The setting for surgery is severe obesity in adolescent, especially with comorbidity. That is BMI more than 40 milligram per meter square. And those who are having serious medical comorbidities. Surgery can be done in adolescents who have reached Tanner stage of 4 or more only, not in a smaller children. They should have demonstrated a commitment for lifestyle changes. They will continue. And they have failed at least 6 months of structured weight loss program. And most important thing is their environment, home and school environment is very, very stable. If unstable home or unstable school performance, they should not go for bariatric surgery. If BMI is more than 35, surgery can be done if they have severe type 2 diabetic mellitus, severe sleep apnea, and or pseudotumor cerebri. Surgical treatment are many, but the principle is it will restrict diet or it will cause malabsorption. So there are many treatment: Roux-en-Y gastric bypass, diversion, adjustable gastric banding, vertical sleeve gastrostomy, or biliopancreatic surgeries. These are the different diagrammatic representation of various surgery. But what happens? Surgery usually leads to massive reduction in body weight, BMI, and fat mass. And this reduction is associated with marked improvement or resolution of obesity-related comorbidities and improvement in mental health and quality of life. So this is the advantage of surgery. But side effect of surgery can be potentially serious, like deep vein thrombosis, pulmonary embolism, pneumonia, GI hemorrhage, anastomotic obstruction, wound infection, polythesis, and sometimes even death. So proper consent has to be taken. So basically motivation and education is important. Post-operative also they are monitored very strictly and properly, especially related to protein, fat, and fat-soluble vitamins, iron, calcium, and micronutrients. This is because adults are growing, so they should be provided with all these supplements. So if somebody is going for surgery, a proper backup of multidisciplinary team is very, very important, which are having expertise. regarding a bit small amount of national policy of controlling food. So national policy should be that this is now public health. This is all individual treatment, but policy regarding prevention of obesity is controlling food import and food labeling. Improving facilities for sports and making streets safe for walking or cycling, and education programs for all which are directed towards promoting healthy lifestyles and explaining the risk associated with obesity. So education should start in school curriculum only. So after effective addressing of this complex problem calls for sustained and multi-sectoral responses involving public, private and health professionals as well as non-governmental sector. And effective policies are required. We are having bilateral burden, that is undernutrition as well as overnutrition nowadays. So it should be tackled very properly. For that, surveillance is required of each and every obese child and lot of studies. The intervention should start as initially obesity starts with balanced nutrition to pregnant mothers, encouraging of breastfeeding, avoidance of catch-up obesity. This is the job of pediatrician. Maintenance of correct growth velocity under guidance of physicians. Avoid excess nutrition even to a stunted children. So malnourished children also should not be on too much of foods. They should be given gradually. Health education is very, very important. Various materials, endorsement of health lifestyles, community mobilization for obesity prevention, that is also important. School-based interventions, that is telling teachers and other people regarding physical activity and nutrition education, that also is important. Home-based interventions, basically this is very, very important. So key goals to address the common dietary problems is encourage in children is set firm limits on television and other media, especially early in child's life. Establish habits of frequent physical activity. So home-based is important. Unless parents and doctors are role models, child will not listen to you. TV, computer time to be restricted. Mandatory 60 minutes of physical activity. And restriction on eating out at weekends and restricting available junk foods at home. So this is important at national level. Central level, what can be done? Creation of national task force for obesity, decreasing taxes and prices for fruits and vegetables, proper food labeling practices and quality monitoring, more playgrounds, parks and walking on bicycle tracks, restriction on advertisement of commercial foods on television, encourage transnational food companies to manufacture healthy snacks, prohibition of promotional gifts with junk foods, ban on monetary sponsorship of youth food festivals, as well as especially cola companies, so youth festivals. So in conclusion, obesity is not disease, it is a public health problem and it is risk factor for several chronic diseases. Understanding the role of environment factors on development of obesity helps in control and prevention. Healthy eating, healthy diet combined with increased physical activity is the answer for prevention of obesity. So as a summary, I can tell there are no miracle cures or products for obesity treatment, no revolutionary diet, no pill or potion till time, no magic. Your will and your lifestyles are in control for weight management. So important is will and lifestyle. For pediatricians, it is important that general pediatrician will have to address this issue at each and every examination point, training at each and every visit, preventive advice at each and every visit, whether it is a well child or ill child. Healthy eating and physical activity behavior should be stressed at visit, and we should be role model for that. Health promoting family environment should be encouraged or corrected at each visit. Thank you very much for patient hearing.
Thank you, sir. Thank you for such a marathon session and for sharing in-depth information on the topic. Almost 1.5
Thank you.
hours is over, and you are continuously explaining everything about the topic. So thank you very much, sir. I think in chat box there are no much questions. So as you say, the first 100 days are important as far as the risk of obesity and overweight is concerned. So first question, sir, the infant of diabetic mother. Are you able to hear me, sir?
Yeah, yeah.
Yeah. So first question is, infant of diabetic mothers, they are large weight at birth. If you start from infancy, so this will be, I think, is the better question. So infant of diabetic mother, as they are overweight, are they prone for developing overweight and obesity in their later life?
In most of the infant of diabetic mother, it is because of a temporary increase in that macrosomia. Later on, they go on losing. But if at that stage, if you go on increasing giving the formula feed, so in especially breastfeed, infant breastfeeding should be continued rather than formula feedings and other things. That is important. That is the preventive factor. So initially they will feel better. The child is very chubby. We have to tell at that level, okay, it will be for a short time. It will be chubby. Don't keep to maintain the child chubby like that only. So we have to give good foods, good supplements only, and don't maintain that weight. So at birth only it should be inward. If it is if it is pathologic obesity because of other factors like nesidioblastosis or some endocrine factor, then it has to be investigated and treated at that. But most of them are just temporary thing. Obesity or macrosomia is temporary. So good again, breastfeeding and good supplementation is required at that stage and counseling.
Okay. So actually that is not a risk factor to later on develop the obesity or overweight.
Yeah, yeah.
Okay. Okay. So in connection with this first one, we most of the time we see a large birth weight child, large for
Yeah.
gestational age. Are they also prone for developing the obesity and overweight in later life?
Yeah, that if that is there, if large other than diabetic infant of diabetes with a large babies are found, we definitely have to do a lot of studies at that stage. If your child is not infant of diabetic mother, then there are probably all those metabolic and genetic factors are there in such children. So we have to follow them developmentally, see whether their development is okay or no. We have to do neuroimaging also in such children, whether hypothalamic factor is there or some endocrine studies also have to be done at initially only rather than delaying the thing. So but that should be everything should be gradually in the stepwise that as I had given into the table how it should go, how much is the and at smaller children weight for length parameter is important rather than BMI. As I said, less than 2 years weight for length. So they should be monitored in the smaller since but by weight to length parameter how much whether it is more than 95th percentile they should be monitored that way. But again, this table is from Nelson, so Nelson has given that table. So the stepwise management of developmental assessment, any other physical examination assessment, and then you investigate gradually or in the flowchart wise manner. That is the important. Even in the small children who are not infantile, so most of the time there is a problems of genetic factors in these children.
Okay. Yeah. The next question is, uh, what is your take on this formula feed? Are they the cause of obesity, especially in a preschool children? Because so many formula feeds are there, 0, 1, 2, almost 3 and 5, up to 5 years. So what is your take on this formula feed, sir?
Yeah. Formula food, what is this? This can be taken as a sweetened beverage. That is what I can say. It is a sweetened beverage. And it is because it is a sweetened beverage, the child goes on consuming. So while advising for formula feed per se are not bad, they are required because of various social problems basically. You cannot tell them it is a bad. You cannot be judgmental कि ये bad है, only breastfeeding is good. Because as you are in the practice, many other problems are associated with starting of formula fluids, like ill child or some other problem. So a proper education, how much to give that formula feed is very, very important. What parents do, we just prescribe a formula feed, they will go on feeding too much till the child is satiated or till child is gulping that thing. So that should be controlled at that stage. You should give the written prescription of the formula feed, how much ml, how should be given. Then probably weight control will be there because otherwise it is a sweetened beverage. They go on taking it, and the parents also go on because child becomes healthy. They go on taking it, and then there is no control. And then again, I don't think lactose, 2, 3 formulas should be encouraged at all. probably one formula is adequate. Two should be replaced by complementary feeding of homemade food rather than the 2 and 3 formula. That is too much. That is my personal opinion.
Yeah, means most of the time, most of the companies are there come up with up to 5 years also. So that's why.
Yeah, that is what. So that is not. In fact, I in my slide also, what this is the pressure in one of my slides that I showed the case patient. The parents had 13 kg 3 years, so I prescribed him some commercial fluid formula, and he became obese 8 kg in that 6-7 months. So that some commercial thing comes into that thing. But unless because that time the child was malnourished, but he became obese, almost near to obesity within 8 months.
What is your take on adding white sugar or a processed sugar in a milk, or for that matter, cow milk above 6 months of age?
Sugar again, as I said, it depends how is the child at 6 months weight wise. If weight is malnourished, okay, sugar can be added, but if child is tending toward obesity, sugar should not be added. Give plain milk. In fact, if plain milk also should be, as per IAP recommendation, milk, animal milk should be given after 1 year of age only. So after 6 months, there is no recommendation by the IAP chapter, IYCF chapter, to give animal milk. After 1 year, animal milk with added sugar or anything, honey or some sort of things can be given, but after 1 year, depending on the weight. If child is obese, don't give this honey or sugar. You can do plain milk, because milk also is the actually filling. 100 ml of cow milk will not give many calories, but it will give a lot of water. It is a filling act. So obese children, this milk without sugar can be given just as a filling thing.
Okay. So, nowadays, new research says some role of antibiotics as far as pathway of obesity is concerned. So my question is there any role as far as prevention of obesity is concerned of probiotics?
Yeah, there are many companies are coming with probiotic things. As I said, microbiome is studied. One of the factor is microbiome studies. But as you know, till now in last almost everybody is more than 10 years of practice. We have practically we know how much they are effective probably, but can be tried. Practically, I don't think they are that effective even in diarrhea or any other thing. Respiratory, lot of respiratory probiotics have come up, but
In COVID also.
yeah, respiratory and all other things. So obesity also some probiotic will come probably in next 2-3 years, and they have been trying. But how much effective in our country as well as cost is concerned, that will be debatable. Those who are having morbid obesity can be tried. Severe obesity.
So,
Actually, vitamin D and probiotics fits in every disease.
Yeah.
almost for every disease, everybody is recommended vitamin D and probiotics.
Yeah. That is that.
Okay. What are those important clues in early life, for example, above 1 year or 1.5 years, which we can pick up seeing a pediatrician will be like a alert for us, then that will actually give us to whom actually we should refer the child as early as like endocrine, or when to take that nutritionist opinion as far as obesity is concerned.
Acha. So if general examination is normal, there is no need to refer to anybody initially. Basically, they will come as an overweight child, not obese. More than 95th percentile, and if you find on general examination or some routine blood test, whatever I said, if there is a problem, then okay. If there is a problem, you can refer to subspecialties. But in India, till now, that as I said, obesity clinic at pediatric obesity, there are 1 or 2 clinics available in some center. So those initial stage you have to change, basically take, as I said, take detailed history, whether they are motivated or no. If motivation is important. If motivation is there, you can refer to centers. If motivation is there, you have to treat at your level only, at frequent, because I said frequent follow-up of the children, as is required for any other reason. You call for immunization or for weight things or some other diet, and you write down the reason that you call after 1 month for this. You at each and every visit give different reasons, and each time counsel them such children. And if you find over 6 month period there is no change in their weight or there is lot of increase in weight over 6 month period, then you can refer probably to some endocrine specialty or some obesity specialty clinics.
Okay. See, one question from Dina. She asked, do we see metabolic syndrome in children? One question from yeah. She asked about, do we see metabolic syndrome in children as a cause of obesity and overweight?
Metabolic syndrome as such is the part of obesity, that is different metabolic syndrome. Metabolic causes or syndrome? Metabolic causes as a etiology of obesity, that is meaning. Yeah, that can be seen where that can be seen in, but that is not common, uncommon causes.
Yeah, means almost 10%. Otherwise, 90% are idiopathic only.
Yeah, very uncommon.
Yeah, means that question was there in our chat box. Okay. See, as far as the policymaker you rightly says, so next question is related to that only. Is there any law which can prevent preparation or advertisement of a sugar beverages, juices, and other products which are rich in calories up to the tune of almost 1500 or 80 gram of fat? So is there any law?
Till now there is no law as such regarding this. Most of the otherwise most of the advertise have been decreased. Government has taken lot of measures to because this printing is there, advertisement, and many colleges also have taken that cola companies will not sponsor these products, etc. So lot of change in UGC guidelines. So these are the changes they have been taken at college, who will take the support of which company. But unfortunately television is still not immune for that. Means they are taking the cola companies and other advertise, but other junk food.
Today, Times of India first and second page is only ad of Kinder Joys.
Yeah, that's true. That's right. That's right. That's why I asked that question. Because
Yes.
most of the time, for example, if you say a cigarette pack, there is an advisory injurious to health. So is there any law which can force the food industry globally to imprint advisory on the such products, especially for those who are school-going people, because they are
Yeah,
the
that
ones who are at risk of developing obesity and overweight in later life.
that is there. Your good suggestion from you. Actually, IAP should, as a IAP, we should follow this thing, this suggestion, and tell the schools also, like some beverage shop, these uh, liquor shops are not allowed around 200 meters of the school. So that sort of activity also has to be taken into the this sort of shops which are giving junk food should not be nearby the school or in the school canteen. School canteens now are little better; they are improving, but still, college, school and college are having these junk food shops nearby. So they should not be there nearby, like a liquor shops are not allowed in this around school, or tobacco ban or other things. So that has to be taken into by.
Prashant, you are saying food items are to be certified by FSSAI, that is Food Safety and Standard Authority of India, but there are no law that they have to just mention on the box. There is no law of prohibition to advertise or to sell. They can sell anywhere, but they have to mention the quantity of each food item, what additives are added. So FSSAI certificate is required, but there is no law that it cannot be sold or something. Just they have to print it on the label.
Yeah, my question was just to for particular age group, especially for a school age group. So
No,
there
no,
is no
law is not there till now. Unless, but law will come. The law usually come also gradually.
correct. As you say, even in school. So is there anything which can promote, as far as our group is concerned, IIT, uh, um, centralized platform can promote compulsory nutritionist in a school where snack and a lunch facilities is available, so that they can take a guidance from a nutritionist and so that they can provide a good healthy snacks as well as lunch in the child.
Yeah, yeah. Some schools they have started all these activities, but these are only urban schools, and but in village, even school canteens are giving all these junk foods like batata vada and other things. That is common in
Yeah, I mean
rural
that's
school.
very hard actually
Yeah.
because
Yeah, so that is nutrition, and but that should come by law. Then only law only will, because employing nutritionists probably because there is dearth of nutritionists in our country. One is psychologist and nutrition. There are not many psychologists and nutritionists, so how can they go everywhere? That is the, but they can be remaining at center only. Sending nutrition in school will be at this stage will be probably impractical. But that is why law should come, as Jitendra said.
yes, that's right. Okay, so I think Dr. Jitendra, if you have any question, you can ask
No.
Dr. Satish and Dr. Mangai. I
Uh,
think sir has taken in
Yeah.
Yeah,
depth
all points are covered actually.
everything right from the infancy till the policy making and everything. He explained in depth about every aspect that he correctly said. Obesity, we cannot deal singly pediatrician. It's a multidisciplinary approach. So on every level, every person should be actually inculcate in the umbrella of a pediatrician. So I think uh, sir has taken it properly. So if you have any question, Dr. Mangai?
no, I think sir has really covered everything in detail, uh, clearing the doubts, including the first 1,000 days and how to prevent, and then going
Yeah,
on sequentially. So,
very
uh,
good.
any
Thank you very much, sir.
thank,
Thank you.
thank you,
Sir,
sir. So, yes, sir.
Okay, okay.
Thank you
So I
very
think
much. I think the
I
program
request
is good.
Dr. Mangai to formally offer the vote of thanks.
Yeah. Thank you, sir. Uh, uh, Thank you, Dr. Vijay Kamale, for this exhaustive, detailed talk on this neglected pandemic. Rightfully said, cognizance and appropriate steps for prevention need to be taken and need to be taken at the right time. Else, we would be staring at a full blown pandemic, this obesity pandemic, which could and can be very much prevented if all of us together, pediatricians, parents, school authority, even the government, all of us join hands, we can definitely do this for the future of our children. And it should be, steps should be taken in that way to curb and control this pandemic. Thank you very much, sir, for your talk. We, as IIP Navi Mumbai kickstarts the IIP Child and Adolescent Healthcare Week celebration, today's talk was very apt and important for a healthy lifestyle, especially for our adolescent and teenage. So, thank you, sir, for your presence, and thank you for being here with us and giving us this wonderful talk. I
Thank you much.
I would also like to thank our moderator, Dr. Prashant VK sir, for moderating this session. Like our president sir rightfully said, Dr. Prashant sir is the apt person for moderating today's session because he is the fit Navi Mumbai IIPM who takes utmost care of his diet and exercise schedule. So thank you, sir, for moderating this session and even going beyond obesity to levels of what steps need to be taken and even questioning whether as a body, central IIP body, whether we can do anything to curb this pandemic. Thank you for moderating this session. I would like to thank the entire IIP Navi Mumbai team headed by Dr. Jitendra Gavani, sir, uh, for all the efforts and all the work that they do. I would also like to thank the IIP Navi Mumbai wing, the adolescent wing of Navi Mumbai, which is the Umang Bhari Udan, and all its members for enthusiastically planning and executing the activities of the Adolescent Week. For all the delegates, thank you for joining us here. And I would like to say we have many activities planned this week. So stay tuned with us and let us all celebrate this Adolescent Week very nicely and successfully. Thank you.
sir, just last note I wanted to tell here, as far as today's topic is concerned, if we summarize everything in a nutshell, So preventive efforts should be begun right from the infancy. First, promoting exclusively breastfeed up to 6 months, and you can extend up to 2 years also. Parents should connect not to use aerated or sugar beverages or juices. Instead, more emphasis on timely introduction of supplement food, vegetable, fruit, grains, etc. Focus should be on family scheduled meals rather than child meal only, and that too not in bedroom. Physical activity promotion should be the part of family counseling session as we do apart from vaccination. I think screening time should be replaced with the family physical activity time, and especially snacking during TV watching and in between the meal that we need to combat. And I think by taking all those small important measures, we can definitely try to decrease the incidence of obesity and overweight, especially in childhood. I think that will be the more contributory thing if we start doing that in our OPD practice. Thank you, sir, because I know the best gratitude one can show is the gratitude. So that's why I'm telling you. Thank you very much, sir. Vijay Kamale, sir. Dr. Jitendra is always there with us. Every time he feels up and on the bottom, every time on the top, who are very enthusiastic and very hakke topic every time. And Mangai and Dr. Vikram is always there. Thank you very much.
Thank you.
Thank you,
Thank
sir.
you very much.
Thank you, everyone.
Thank you, Sandeep.
We are the NMAP.
We heal with zeal.
Together we navigate
New frontiers.